Welcome to this explainer. If you work in clinical practice dealing with liver disease, you probably know firsthand the absolute frustration of relying on subjective imaging. We've all been there, right? You're staring at a monitor, debating with yourself whether a liver looks, bright enough to classify as steatotic. Well, today we're setting all that guesswork aside. We're going to explore how modern quantitative ultrasound is completely transforming hepatology by replacing those subjective visual assessments with hard, objective numbers. So let's dive right in. The ultimate clinical challenge we face every single day in practice is really simple. How do we accurately quantify liver fat without being invasive? We absolutely need precise data to make treatment decisions, but we obviously can't subject every single patient to a liver biopsy. The answer to this question is fundamentally changing the front line of metabolic liver disease management. Here is our quick roadmap for today. We'll be covering the threat of MASLD, steatosis grading criteria, the limitations of traditional assessment, quantitative ultrasound as the solution, comparing CAT versus guided QES, and finally, the practical clinical utility for physicians.
First up, Section 1, the threat of MASLD. It's truly a global wave.
Metabolic dysfunction-associated steatotic liver disease, or MASLD, is a massive global issue. Think about this. It currently affects more than 30% of the general population worldwide. Now, historically, the absolute gold standard for diagnosing and staging this has been the liver biopsy. But let's be practical here. Relying on biopsies as a widespread screening tool is completely unfeasible. It brings high medical costs, it's invasive, there are morbidity risks, and frankly, it's really prone to sampling errors and inter-observer variability. You can't biopsy a third of the planet. We desperately need a better way. Moving to Section 2, steatosis grading criteria, where we target the exact fat content. Take a look at how the Brunt criteria break down our target. This is super important. Hitting these specific thresholds matters immensely for how you manage your patients. Grade 0, or S0, means normal, so less than 5% of hepatocytes contain fat. Grade 1 is mild steatosis, jumping from 5 up to 33%. Grade 2 is moderate, spanning 34 to 66%. And Grade 3 is severe, representing over 66% fat infiltration. For us as physicians, our clinical utility completely hinges on being able to accurately place a patient into one of these specific buckets. Why? Because the medical intervention for an S1 patient is vastly different from an S3 patient.
Section 3, the limitations of traditional assessment. Basically, why the old methods are failing us. The crucial takeaway here is the stark contrast between the old and the new. Conventional B-mode ultrasound is what most frontline clinics are still using today. Yes, it's cheap and yes, it's accessible, but it's entirely subjective, it's qualitative, and it's highly operator dependent. And the most alarming part, it regularly misses VAT content below 20%. That means you are completely missing early-stage grade 1 steatosis. On the flip side, quantitative ultrasound, or QUS, provides objective, numeric data that is highly sensitive to even low-grade fat accumulation.
We have all been trained to look at the hepatorenal index, right? As clinicians, we look for increased echogenicity, that classic bright liver, or the blurring of vessels in the diaphragm. But trying to assess the contrast between the liver and the right kidney just by eye is incredibly subjective. Depending on the machine settings or even just how tired the operator is that day, early disease is so easy to overlook.
All right, Section 4, the solution. Let's talk about quantitative ultrasound and getting those objective measurements.
The whole foundation of this revolution is the attenuation coefficient. Let's simplify the physics a bit. As an ultrasound wave passes through tissue, it naturally loses energy due to absorption and scattering. Well, the presence of fat in the liver significantly increases this attenuation, causing a signal delay. What these new algorithms do is actually measure that exact energy loss. We're literally taking a physical change in the liver tissue and turning it into a precise measurable number expressed in decibels per centimeter per megahertz.
To anchor this concept in your daily practice, you need to know the baseline. In normal, healthy biologic tissue with no fat infiltration, the expected range for the attenuation coefficient in the liver is roughly 0.43 to 1.26. When a patient's numbers start climbing above those thresholds, you have hard, objective evidence of steatosis, way before the liver simply looks bright on a conventional monitor.
Section 5, CAP versus guided QUS. Let's compare the algorithms. Let's start with the most widely studied commercial algorithm out there, the controlled attenuation parameter, or CAP. typically measured via transient elastography systems like FibroScan. CAP has been around since 2010 and has some really robust clinical data backing it. However, it is vital to know its limitations in the clinic. CAP's diagnostic accuracy decreases notably in patients with higher body mass indexes. Plus, it's a blind measurement. You don't get a live B-mode image to see exactly where the probe is sampling inside the body. This is where B-mode guided quantitative ultrasound comes in, brilliantly solving that blind problem. Whether you're using systems like ATI or UGAP, you can actually see color-coded attenuation maps laid directly over the B-mode image. This is a game changer because you can consciously avoid large blood vessels, masses, or artifacts. You ensure that you are sampling pure liver parenchyma, which gives you a much more accurate reading. And the diagnostic power of this guided approach is undeniable. When looking at the area under the curve, which is a key metric for diagnostic accuracy, studies have shown that attenuation imaging, or ATI, hits an impressive 0.892 for detecting steatosis. To put that into perspective, in head-to-head comparative studies, it beat out CAP, which scored a 0.829. Guided QUS gives you superior accuracy simply because you control exactly what you are measuring. And the technology is pushing even further now. We have next-generation tools like the ultrasound-derived fat fraction, or UDF. Instead of just looking at attenuation alone, UDF is a composite parameter. It combines the attenuation coefficient with the backscatter coefficient, which essentially measures how the sound waves bounce back off the fat droplets. The system then runs an algorithm to map these acoustics directly to an estimated fat percentage. It's essentially attempting to give you MRI-level diagnostic data right from a standard ultrasound probe. Section 6. Practical clinical utility for physicians. How does this impact your day-to-day practice? This truly represents a paradigm shift for patient care. First, it directly avoids unnecessary invasive liver biopsies, which slashes risk and medical costs. Second, it empowers you to objectively stage a patient from S0 to S3 right there in the clinic, allowing for immediate targeted interventions. Third, because it's quantitative, you can track longitudinal patient progress over time. Did that diet and exercise regimen actually work? Now you have a hard number to prove it, not just a subjective visual opinion. Furthermore, because it's B-mode guided, you're simultaneously assessing overall liver morphology, checking for tumors or portal hypertension. And best of all, it's highly accessible right at the point of care. To summarize the massive advantage we've discussed today, it really all comes down to this core truth from the literature. B-mode guided US for measuring hepatic fat content allows visualization of the area to be sampled while avoiding artifacts. Seeing exactly what you are measuring ensures the absolute highest quality, most reliable data for your patients. You aren't guessing anymore. You are calculating. Thank you so much for joining me for this explainer. Considering the rising global tide of metabolic liver disease and the really clear limitations of subjective visual scans, we have to ask ourselves, is your clinic ready for the quantitative ultrasound revolution?